Hello, everyone, and welcome again to today's webinar hosted by Critical Path Institute's Rare and Orphan Disease Program. My name is Dominique Cruz, and I'm a project manager for the Rare Disease Cures Accelerator Data and Analytics Platform, or RDCA-DAT. RDCA-DAT provides a centralized and standardized infrastructure to support and accelerate rare disease characterization with the goal of accelerating therapy development for rare diseases. It's my pleasure to welcome everyone to today's webinar, Hidden in Plain Sight, Autosomal Dominant Tubulointerstitial Kidney Disease. Before we begin, I'm going to start with a few housekeeping items. If you have any questions throughout the presentation for our speaker, please put them in the Q&A box. The chat function is disabled, just so we make sure we aren't missing any questions that pop up, and all participant lines are muted so we can reduce background noise. We are recording this presentation and it will be available for on-demand viewing on CPAT's YouTube channel. Now I'm pleased to introduce Dr. Soren Fidelis. Dr. Fidelis is the Executive Director of the PK-DOC Consortium at Critical Path Institute. He's been with CPAT since 2021 and has led PK-DOC in overseeing strategic vision, management, and activities of collaborative research endeavors with various stakeholders to accomplish the objectives of the consortia. Dr. Fidelis, I'm happy to hand it off to you to introduce our speaker for today's webinar.
Thank you very much, Dominique. Hello, everyone. It is my great pleasure to introduce Dr. Anthony Bleyer from Wake Forest University School of Medicine. Dr. Bleyer is a professor of nephrology, internal medicine at Wake Forest. He has adjunct appointments at the Broad Institute at Harvard Medical School and MIT, at the Institute of Inherited Metabolic Disorders at the Charles University in Czech Republic. Dr. Bleyer has made seminal contributions to the ADTKD field. His team has identified, was the first one to identify mutations in the UMOD gene as one of the main causes of autosomal dominant tubulointerstitial kidney disease. He has built the largest registry in ADTKD at Wake Forest and has built and has been leading the rare inherited kidney disease team there for the last 25 years. So it is our great pleasure to welcome Dr. Bleyer to present today. Tony?
Soren, thank you very much. And I'd just like to say what a pleasure it has been working with you and with your group and how you're helping so many people with these rare diseases. So today I will be speaking really about my life's work, autosomal dominant tubulointerstitial kidney disease. Next slide. And so my disclosures, I'm on the editorial board for Renal and Urology News, and I'm also a contributor to Up to Date, and I work with Natera on the advisory board. Next slide. So this is our team mission statement, and it is to help one patient, one family at a time. Next, as you can see, I have a really great team. A lot of times people put this slide of their team at the end, but I put it at the beginning because they're so integral to our work. And standing to my right in that picture is Vicky, is our research nurse who has been working with me for 20 years. And she's really helped, as well as all of the team, to really be focused on our patients and to see what we can do to help them. Next slide. So first, I'd like to just start off with some challenges of working in the rare disease space. Next. In the US, a definition of rare disease is a disease that affects less than 300,000 people. And it's 30 per million in the EU. And as you can see, many of these diseases affect few people. However, 70% of these diseases are genetic. And when we add up all the rare diseases that occur in all the people, it's not so rare. It's one of the more common disorders in the top 10 of diseases in the US. Next slide. So challenges to rare diseases include identification of the disease, diagnosis, and research and treatment. Next slide. Next. So with identification, only rarely will a doctor you see know what the disease is when you see them. And the symptoms of the disease may be mundane. So this may be the very first time that the doctor sees the patient. Research tools may not be available for the disease. So people don't know very much about the disease. It hasn't been studied very much. The doctor seeing the patient hasn't seen these cases before, and all this makes things very difficult. And then if you do find this disease, what do you do as a doctor? How do you identify other workers who can help you with the disease to learn about it? And then when you want to study the disease, where will you find funding? So at every step of the way, it's really difficult for someone to identify a rare disease and to even find someone who can make a diagnosis. Next slide. And then when we think of rare diseases, how many diseases does the doctor know about? You know, we know about the top 10, 20, maybe 100 diseases that we will see. But some of these rare diseases we will only see once in a lifetime. Then doctors may not always be curious, you know, just like you or me. For example, my granddaughter Matilda is very curious, and she will go into everything and explore everything that we have in our house. But other children, some of my other grandchildren may not be as curious. And so it's similar with doctors. Doctors may see something, they don't understand what it is, and they may not reach out and try to learn about what that condition is. Doctors may be taking care of a lot of patients. They may see 20 patients in a day, and they may simply not have enough time to spend 2 or 3 hours to try to figure out what a patient has. Physician extenders may have less medical training. They are seeing more and more patients. They may be less likely to make a diagnosis as well. And then curiously, doctors, especially nephrologists, tend to guess at diagnoses. So for example, I might see a patient and say, did you take Motrin a lot during your life? And they may say they took Motrin for 2 or 3 years. And I might say, well, I think your kidney disease is due to Motrin. Or we might say, oh, how long have you had high blood pressure for? And was it always well treated? And we may ascribe it to high blood pressure. We may ascribe kidney disease to toxins like Agent Orange. But a lot of times we may be guessing about this, and we may not have a real diagnosis, especially when it comes to rare disorders. And doctors may not actually be incentivized to make a diagnosis. They're seeing many, many patients a day, and making a diagnosis may not be the leading thing for them. They may be worried that there's no treatment for the disease, and so they don't really feel a big need to make a personal identification for the patient of what the disease is. Next slide. This is especially true when it comes to dialysis and kidney disease, unfortunately. And so as you can see, when you look at this vortex, and there's the patient in the middle represented by the kidney. There are a lot of dialysis organizations in the United States, businesses, and they provide excellent care to patients. And these businesses make it easy for us to take care of patients, but paradoxically, that also makes it easy for us to place patients on dialysis. And so patients can be placed on dialysis relatively easily, and doctors get medical fees for the patients being on dialysis. I don't think doctors push patients onto dialysis to make money, but I do think that there's an easy path for patients to get dialysis. Now, let's contrast that with transplant. Transplant is very difficult to get a transplant. You have to see if you have a donor. You have to go and have a long interview and make sure socially that you're able to do this, and also that medically you're able to. The same way with the treatment. Diagnosis, you might need genetic testing. A treatment may not be paid for by your insurance. There may be limited research on your disease. So in the US, unfortunately, it's very easy to place patients on dialysis, but it's harder to come up with diagnoses and treatment and get them transplanted. And if you're interested, there's an article that I've written on this that's referenced in the lower corner there. Next slide. If we look at the causes of end-stage kidney disease in the United States, approximately 25% of patients are said to suffer from hypertension as a cause of kidney disease. And as you know, there are millions of people in the United States with high blood pressure, but only rarely do people with high blood pressure go on dialysis. And in addition, patients with kidney disease all eventually will develop high blood pressure. So the diagnosis of hypertension as a cause of end-stage renal disease is really vague and not correct. So you can see from this graph, at least 25% of our patients who go on dialysis or need a transplant, we don't have a cause for their kidney disease. Next slide. There are challenges in the disease. The researcher who finds a genetic cause for kidney disease may not be the same researcher who is then going to study the disease. So we studied our UMOD mutations, which I will talk to you about. We found the genetic cause of that disease. And then we decided to pursue this and study this disease lifelong. But some genetic researchers may identify a genetic cause of disease, and that's their expertise, the genetics. And then they may move on to the next disease to find the next gene, but they may not be the same people who will then be doing research in this area. So this is a really big problem for patients with rare diseases, to get this connection between the underlying genetics and then for someone to take this disease and develop a treatment and understand the clinical consequences of it. Next. So the challenges that we see for this are the rarity of the disorder. So how often does this disorder occur? Then the disease, in order to identify a treatment, we have to characterize the disorder. So if we have a disease and we have a potential therapy, how do we know if that therapy is really helping the disease? So we have to know the natural history of the disease, how the disease is progressing, before we can even begin to talk about a treatment. Then if we have a potential treatment, we need to find where the patients are. So if I study diabetes, I can have a center in anywhere in the United States and get hundreds of patients for my study. But for rare diseases like we study, like ADTKD, which I'll talk to you about, it's very hard to identify even 20 to 30 patients in a geographic area. So studies have to be very geographically dispersed. Then these different academic centers may not be interested in participating in studies because they may only be able to recruit 1 or 2 patients for a study. And so they have to go through a lot of work, protocols, their IRBs locally, and do many, many things, work up budgets, get them through the budget office. And that may not be worthwhile for them to do for a study where they only recruit 1 patient. And then, of course, we're also not only not having enough patients, it's hard to get centers to do studies, but then we have very little statistical power. Pharmaceutical companies also may be less likely to invest in these rare disorders. Next slide. So as you can see, it's really difficult to treat these rare diseases and to diagnose them, first of all, then to identify a therapy, and then to identify a treatment. So now I'd like to just talk about the diseases that I study. And the disease we study is autosomal dominant tubulointerstitial kidney disease. Next slide. Next. And so this is a disease that patients present with chronic kidney disease, often beginning in the teenage years, with variable progression to end-stage kidney disease between 30 and 80 years. Patients have a bland urinary sediment. There is no urinary protein. And this is a really big problem for us for 2 reasons. First of all, doctors see these patients and they don't understand what these patients have. They're not sure what the disease is because almost all kidney diseases have urinary protein. And the other big problem with which Soren is working with us is urinary protein is an excellent biomarker for glomerular diseases, and we don't have this with ADTKD. So treatments like, for example, ACE inhibitors, they're drugs that we give to treat diabetic nephropathy. And they can be tested in any disease with proteinuria. You give the patient the drug, and then you see if there's a drop in urinary protein. And that's a really good marker that treatment will be successful. Unfortunately, when we don't have urinary protein to study, we cannot see if these ACE inhibitors or other therapies, we can't tell quickly if these will be good therapies. When we look at the ultrasound of our patients with these diseases, they have normal or small kidneys. So taken together, the patients have chronic kidney disease, they have normal to small kidneys, they have no proteinuria, and they have slowly progressive disease. The best marker of the disease is that the diseases are autosomal dominant, that our parent and child are both affected, and that this, if we're taking a good family history, this is one of the key ways in which we can identify this disorder. Next slide. And here is a characteristic presentation. It's actually from the first family that we ever studied. And the doctor said, the patient told us, my doctor found my creatinine was elevated when I was in my late teens, early 20s. I have many family members who have kidney disease. But my doctor is confused because my urinary sediment is normal and my kidney ultrasound is normal. And so we've heard this particular presentation many times. Next slide. Now I'd like to go through the clinical manifestations a little more. Next slide. And so we started studying these families in 1996. When we were referred a family in the mountains of North Carolina. And if you look at the picture on the top right, the doctor is Dr. Woodard. He was a family practice doctor. And so this doctor was very curious, and he was very interested to identify why this family that he lived near had this disorder. And those were the two medical students I worked with at the time. And those are my two sons who are now starting their medical residencies. So we've been at this for some time. Next slide. So we were able to identify mutations in the UMOD in 2001 as a cause of inherited kidney disease. And then we started identifying other families. When we started, we thought maybe there would be 3 or 5 families in the United States that would have these UMOD mutations. So we started a website, and the keywords were inherited kidney disease, autosomal dominant, chronic kidney disease, and the UMOD patients have a gout frequently, so we included that as a keyword. And soon we were accumulating more and more families, and we found that not all of them had UMOD mutations. So then we started to try to identify a new mutation as a cause of disease. I started working with Dr. Stan Kamach, and we identified mutations in renin as a cause of inherited kidney disease. And then we had many families we couldn't identify the cause of kidney disease. And we started with working with Dr. Eric Lander at the Broad Institute, and we were able to identify MUC1 mutations as a cause of inherited disease. Next slide. And so when we started, we thought that we would have very few families that have this disease. But as you can see, over time, we now have 1,100 families that we've identified. Now, interestingly, if you look at the top left corner of the slide, we have more than 200 families. Go back one slide, please. We have more than 200 families, almost 25% of our families were directly referred from our website, and they did not get referred to us by doctors. Curiously, the patients were as good as making a diagnosis as both the doctors in private practice and in academic practices. So we reached out to all different groups to identify families with the disorder, and we were able to identify so far more than 1,000 families with the disease and over 200 families with UMOD mutations. And now over 200 with MUC1 mutations, also families with many other disorders. And so from a disease that we thought was rare and had only rarely been diagnosed, we find that there are increasingly more and more families with this disorder. Next slide. What is the prevalence of ADTKD? In a study by Groupman et al. From the New England Journal of Medicine, they identified that 0.3% of patients on end-stage kidney disease have UMOD mutations, making it the third most common genetic disorder. We believe that there are an equivalent number of patients with MUC1 mutations, so that would be another 0.3%. And there are actually 700,000 people on dialysis in the US. So 0.3% of 700,000 is 2,100. We then looked at our registry and we saw that we have 3 patients who are not on dialysis for each patient on dialysis. So that was a total of 8,300 patients, or 6,300. And if we do that for both diseases, we can see 12,000 next. So we have at least 12,000 patients in the US with this disorder. Now, you may say, like for me, I was like, well, how many patients is that? Like, I had trouble understanding that. And the best thing I can tell you is that every nephrologist has one patient in their practice or one family that has this disease. I'd like to now talk about our most common type of disease, which we first identified was mutations in the UMOD gene. Next slide. So ADTK-UMOD is caused by mutations in the UMOD gene encoding uromodulin, which is, we used to call this Tam-Horsfeld protein, and it's the most common protein identified in the urine. This causes ADTKD, which we talked about, chronic kidney disease, autosomal dominant, but it also causes gout presenting in late teenage years. Approximately 50% of the patients who have this disease are found to have gout. Next slide. Here you can see uromodulin on the left. It is on the right. It is a protein with the highest cysteine content in the body. And the cysteines, you can see the monomers go together to form a sheet, and the sheet lines the tubule and then is slowly excreted into the urine. The high cysteine content requires prolonged ER transit for protein folding, and this is what makes hyaline casts. 50% of mutations causing ADTKD-UMOD affect the cysteine residue. Next slide. And here you can see the many different mutations that we've seen over time, and these are denoted in red and light blue on the screen, with 50% of the mutations being an addition or a subtraction of a cysteine residue. Next slide. I like to think of the cysteine residue as knobs on a Lego block. And you can imagine if we took a Lego block that had 4 round knobs on the top and put a square knob, that we would not be able to make our Lego set. And in a similar way, the cysteine mutations cause changes in the protein that don't allow it to fold properly. The mutated uromodulin cannot get to the surface of the thick ascending limb, and it deposits within the cells. The cells then become leaky, allowing sodium to be excreted in the urine, and this leads to increased sodium and urate uptake in the proximal tubule, leading to gout in our patients. So this is why our patients have gout. But the key thing, as you can see from this slide, is we change a cysteine residue or another amino acid. The protein cannot fold properly. It deposits within the cells of the kidney. Next slide. As you can see on this slide, the disease occurs. Can you see the red box in the middle? It occurs in this disease in the tubules. So it occurs in the thick ascending limb, not in the glomerulus. And because of this, we don't have urinary protein. Next. This is a good disease, we would think, to study for urinary biomarkers. The reason it's good to study for urinary biomarkers is the disease occurs after the glomerulus, so there's no problem with the filtering. So if the glomerulus breaks down, a lot of different proteins from the blood can get into the urine. But in our disease, this does not occur. And so what happens is the urine goes straight out, and any mistakes that are or any changes in the proteins that occur in the thick ascending limb will then go straight into the urine. So we should be able to see like markers of inflammation or fibrosis in the urine. And we can also study these patients from a young age because we can study to see if they have the mutations that cause the disease. And so it should be very good for finding biomarkers, though we've had difficulty doing so. Next slide. One benefit of working in rare diseases is that we have the internet. And so we're able to connect with many other doctors who study these rare disorders. And I find that doctors who study rare diseases in general are really, really nice. And so we've been able to collaborate with many different doctors over time. And here's a study we did of 722 affected individuals from 249 families with 125 mutations. And I show all the authors here to show that we had over 15 centers that helped us to characterize this disease. Next slide. And as you can see, the median age of end-stage kidney disease, this is a survival plot. The median age of end-stage renal disease is 47 years, and men were at a slightly higher risk of progression than women. Next slide. Now on this slide, we can look at each column, and each column represents a family, and each dot in the column represents a different family member. And we can see that for the first column, we have patients, 3 patients going on dialysis before they even reach age 20. And then as we go towards the right side of the graph, we can see one of the larger families on the end, they have family members who started at dialysis as young as 20 and as old as 70. So there's a tremendous variation in the age of disease, even within families. And this also makes it more difficult to study. Next slide. So as you can see, UMOD is a protein that's expressed in the thick ascending limb of the kidney. We're actually still uncertain of its function. We think it's very important in sodium reabsorption. This test is commercially available, and we do test children with this disease because gout is so prevalent, and we can help to prevent gout. Next slide. The next disease that's common in ADTKD are mutations in MUC1. Next slide. So MUC1 is the purest form of chronic kidney disease. Patients have an autosomal dominant disease, bland urinary sediment, so no blood or protein in the urine, and variable progression to end-stage kidney disease between 30 and greater than 70. The sole clinical manifestation of this disease is chronic kidney disease and the sequelae that occur from chronic kidney disease. And as you can see, why I say this disease is hidden in plain sight, because many doctors were never able to make a diagnosis of this disorder because it has such a bland presentation. Patient comes in, no blood or protein in the urine. They may or may not mention their family history. And only through genetic testing have we been able to identify many, many families that suffer from this disorder. Next slide. And this was extremely difficult to find the genetic cause of this disease. And we were fortunate to work with Dr. Eric Lander at the Broad Institute of Harvard and MIT, and he was able to identify this mutation. Next slide. So what is MUC1? MUC1 is one of many mucinous proteins that lines many different epithelial cells in the body. It functions in signal transduction, but it also is a protective protein. It's a mucoprotein, so it forms a mucus aligning on many, many different epithelial cells throughout the body. So for example, the gastric mucosa, there's mucin 1, the nasal epithelium, the lung, all of these have mucin 1. Now, often the mucins are present as a group. So in the lung, you might have mucin 1, 3, and 5. In the kidney, you may have 1 and 4. And in the stomach, you may have 1, 7, and 10. So we have about 20 different mucins, and they're distributed on in different ways on the different cell surfaces. In the kidney, they're only expressed in the thick ascending limb and early distal convoluted tubule. But they're also, MUC1 is also expressed in the lungs, the breast, the stomach, and the nasal mucosa, as we discussed, and in the sebaceous glands. Next. Patients with MUC1 mutations have a very peculiar mutation. So what they have is there's a repetitive unit in the MUC1 gene, and this repetitive unit forms a group of 20 proteins to which sugar residues attach, giving the protein its mucin structure. And we have between 20 and 150 of these repetitive units to which these sugars attach. And our patients, as you can see on the first line here, they have an addition of an extra cytosine residue to a string of 7 cytosines. And this leads to a frame shift mutation in which the 20 repetitive unit of amino acids still exists, but now the amino acids are all changed because of the frame shift. And these new amino acids are very basic, and they lead to deposition of this protein within the tubular cells of the kidney, as well as throughout the body. Next slide. So as you can see here, the red is the neopeptide, the new protein that is formed. And in the figure on the left, you can see the one normal MUC1 molecule that is tied to the apical surface. And then you see the one with the red tail that stays intracellularly. And this a part of the MUC1 molecule, or this mutant MUC1 protein, gets stuck in between the endoplasmic reticulum and the Golgi apparatus, and these little shuttles that go between it, called the endoplasmic reticulum Golgi intermediate compartment. They lead to stress in this area. I like to think of the mutated MUC1 protein like plastic in the ocean. It's something the body has never seen before and doesn't know how to get rid of. And so it accumulates over time and leads to stress within cells. Next slide. Here we can see MUC1 staining in the skin and in breast tissue, represented in brown on both of these slides. And so it's really interesting that MUC1 is expressed in many different cells in the body, and the mutated protein also occurs in many different cells in the body, but we only see kidney disease. And we think this is because most of the other cells, like the skin and the gastric mucosa, have very high turnover. And so there's not enough time for the mutated MUC1 to accumulate and cause problems. Whereas the tubular cells in the kidney do not turn over for long periods of time. And we think this allows the protein to accumulate and exert a toxic effect over time. Next slide. As you can see, the age of end-stage renal disease varies within and between families in a similar way between the UMOD and the MUC1 families. So when I look at these families, it's very, very difficult for me to tell any differences except for the presence of gout in the UMOD families at an early age. Next slide. So our quandaries are, if MUC1 frame shift is present in many tissues, why does it only cause pathogenic changes in the kidney? Next slide. And why do some patients go on dialysis at 20 and others in the same family at greater than 70? And so these are things that we're exploring right now. Next slide. The Broad Institute did a high throughput screening trying to identify drugs that would help to remove the frame shift MUC1 from the urgic and to excrete it out of the cell. Next slide. And Dr. Anna Greca of the Broad Institute led this study, and she was able to identify a compound called BRD 4780 that we see is a potential effective therapy. And as you can see on the top of the slide, and I'm sorry I don't have a pointer, due to technical difficulties, I wasn't able to have this. But if we start at the top panel and we look at the right side of it, that is the ER. And then we have to transmit proteins or transfer proteins from the ER to the Golgi. And this is done in these little vesicles called COP1 vesicles. The COP1 vesicles have a protein on them, a carrier protein called TMED9. If you look at the middle frame of this picture, you can see that the mutated MUC1 protein binds to TMED9 and it won't let go. And this makes TMED9 accumulate in the ergic and it causes stress in the cell. As we can see in the bottom panel, the Broad compound attaches to the TMED9, releases the mutated MUC1 protein, which then goes on to the lysosome. So we think this is a potential effective therapy for this disease, and this is being developed as we speak as a potential treatment. Next slide. When we look at the kidney on the left here, this is a mouse kidney. The green is the MUC1 frameshift protein. And as you can see, the tubular compartment of the kidney is very big, and you can see a lot of green there. The panel on the right is a normal mouse, so it does not have the MUC1 frameshift protein, so there's no green. After treatment with the Broad compound for a week, we can see in the middle panel that almost all of the green is gone, showing the effectiveness of this therapy. Next slide. Regarding ADTKD MUC1 testing, this is a very difficult test to do, and it's only done at the Broad Institute of Harvard and MIT. It is a clinically approved lab. All samples for testing must go through Wake Forest, and the good thing is the testing is free. So if you have any patients with autosomal dominant inherited kidney disease, we can test them for free. Next slide. Oh, yes, and this test is not, if you do a gene panel, whole genome sequencing, whole exome sequencing, these techniques will not identify the mutation. And so this is one of the very rare diseases that you cannot see in a whole genome screen or in a gene panel, but requires dedicated testing. Next slide. There are also other mutations that can cause this besides the C duplication, and our colleague in Prague, Dr. Stan Kamach, works to identify other families that may not have the C duplication. Next slide. So in summary, the MUC1, we know MUC1 works as a protective on the surface of cells to lubricate cells and to protect them. The testing for MUC1 can only be done at the Broad Institute right at this present time. And we in general do not do genetic testing of children with this disorder, as the patients don't develop gout and the age of end-stage kidney disease is usually way past adolescence. Next slide. Just as an example, we were studying glucose uptake inhibitors to see if they would be helpful in patients with ADTKD. We know they're indicated in almost every type of chronic kidney disease. So we did a nested cohort study of 12 patients that had been started on SGLT2 inhibitors by the doctors. They were well tolerated, and we looked at kidney function decline over time. Next slide. If you look at this slide, you can see on the left are the patients who had chronic kidney disease from the New England Journal of Medicine article of SGLT2 inhibitors. And the blue line shows just the patients who had chronic kidney disease. So when you look on the right side, or the blue line, I should say, shows patients who are getting the SGLT2 inhibitor, and they have an improvement in kidney function over time compared to the red line. Now on the left side, we see, can you go back? Yeah, on the left side, you can see our patients that we treated, and they're presented in red. And the blue line represents the patients who are treated in the New England Journal of Medicine article. The first thing you'll notice is that our line is not smooth at all. And the reason for this is we had so few patients in our trial. And I just wanted to show this to highlight that even though we have a potential therapy, we can't really tell if it's working because we don't have an effective biomarker. Next slide. And you can skip this slide. Next slide. We have many other potential therapies, such as antisense oligonucleotides, 4-phenylbutyric acid, which is a chaperone protein enhancer, other conventional medical therapies, and stem cell therapies potentially. But our big problem is we don't have a way to show that these medications might be effective. The only thing that we have is to follow kidney function over time. As we showed before, this is very erratic. Some patients lose kidney function much more rapidly than others. And so it's difficult to identify a population at risk, and then how to study changes over time is very hard. Next slide. So we therefore need a biomarker. We would think that we have an ideal disease to study biomarkers because our disease is located in the tubules. We can do genetic testing and find younger patients who don't have a lot of scarring or fibrosis. And we have specific mutations that we can look at in a specific protein. Unfortunately, in our work so far, we have not been able to identify any good biomarkers. Next slide. We studied MANF, KIM1, uromodulin, NGAL, DKK3, and TNF, and we haven't really been able to show that elevated levels of these biomarkers are associated with the rate of progression. Next slide. We're also interested in imaging modalities. We know that CPAT did an awesome job with ADTKD looking at cysts, and that's really cyst size and kidney size. And that's really revolutionized our ability to identify therapies for this disorder. And so we're hoping to use artificial intelligence, look at MRI, and potentially look at ultrasound to see if we can find any anatomic indices that would be helpful biomarkers. Next slide. We also need to better characterize disease progression. We need to better understand the rates of disease progression. So we currently have a cohort study of 150 patients with ADTKD, and we're following them over time, getting labs every 3 to 4 months. And we're doing electronic surveys of the patients every 4 months. An advantage of this study is that we're able to go international, and we're able to also get patients from all over the United States. They're sending in their lab values to us, and it doesn't require a large amount of work by our team, so we can have many, many, many patients in the study. Next slide. And we are also interested in other rare inherited kidney diseases. And as you can see, based on our success in identifying a lot of collaborators who had UMOD families, we're also looking at other rare diseases to see if we can help to identify characteristics of disease. Next slide. So we really appreciate our collaboration with the Critical Path Institute. We really are looking to identify biomarkers. As a small team at Wake Forest, we really need to leverage help, especially statistical help and analytical help. So we're really super happy to be working with our colleagues. Next, and especially our good friend Soren. Next. And so here is our team at Wake Forest together with our team in Prague. And this was in front of the statue of Mendel at his monastery. And so we'd like to say we stand on the shoulders of those who came before us. We're just doing simple Mendelian genetics. And we're really appreciative for all you attending today. And if you have any questions, I'd be happy to answer them. Thank you.
Thank you so much, Tony. Wonderful talk. Really, really awesome and great to, to have started our collaboration. And, we're very excited to continue working on this. We have a few questions. partly covered the answers, I think, but I'm still gonna ask you. I guess the first one would be regarding therapies. Like, what do you think is exciting out there? You mentioned a few, but if you had any other thoughts on that. And then the second question would be about patients and how can we get them to participate in trials, knowing what we know about the disease, diagnosis, prevalence, etc. So those would be the first two
Yeah,
questions.
so the first thing is, I think there are a lot of potential therapies, and I'm super excited. And I feel like we're just really now getting to the stage where these therapies might be useful. We developed a lot of anti-fibrotic drugs, like finerenone, and then also I'm interested in SGLT2 inhibitors, and just some of the drugs for chronic kidney disease. On the other end of the spectrum, I'm interested in CRISPR and other genetic techniques. And then I'm interested in the specialized drugs like the Broad Institute has developed. I think these large drug screens are going to help identify different compounds for us. So, and then even diet, I'd love to know if like a low protein diet or a vegetarian diet would be helpful. You won't believe how many patients ask me about diet, and they're super interested in that. So I think there are a lot of potential therapies that we could even go at right now. We have mouse models and we're developing rat models that we can test them on. But as I said, our big problem are the biomarkers. Now, in terms of getting patients into studies, I think if you care about the patients and you interact with them as a group, I think that's the best way. And I think it's just by nature from our team. Like our team, can I just say, is very caring. And so we started working with these families, and we act like they're our families. That we really care about them. Some of these patients, unfortunately, I diagnosed when they were little children, and now they're proceeding to needing kidney transplants. So we're always open and available to our patients. We have a Facebook page. We have a family foundation. I give webinars. Whenever I speak anywhere in the country, if I get asked to speak somewhere, I always have a meeting with the families. I was at Northwestern a couple months ago, and we organized a meeting of families in Chicago. And so then when the families see that you're invested and you really care, and they're in our longitudinal study, then they're more motivated. And the thing that motivates them the most is it's autosomal dominant. And they know that their kids can get this disease. And they know so many family members have done poorly, or not poorly, but have required dialysis or transplant over time. So getting our patients motivated isn't particularly hard in our disease because they see what's happened to family members. And then we interact with the patients closely. And then the other thing we do is we're following their chronic kidney disease over time. And so we kind of already almost have them in a study. So what I like to tell our patients is when we start a clinical trial, we don't want to start, the gun goes off and you start running. I tell them we want to be running towards the starting line. So we want to be running, and we have the data, we're collecting it. And so we feel that we're ready when the time comes.
No, that sounds really encouraging, Tony. So we had a question from the audience. Again, you touched upon this, but if there was anything else you wanted to add. So someone asked, can there be radiodiagnostic procedures that would show up any anomalies? Has MRI, PET, or other methods been tried?
So in terms of diagnosis, we have the genetic test now. So with the genetic test, we're less reliant for diagnosis. However, we're super interested in these tests for potential screening or to help doctors to identify the disease. It's possible if we had MRI that we could see very small changes in the middle of the kidney, in the medulla of the kidney. The problem is most patients don't get an MRI, so it wouldn't tip most doctors off to this diagnosis. Now, we could get the MRI, and I think that's one of the things we're interested in looking at, to see if there are any changes that, especially artificial intelligence, could help us identify that point to this disease or point to progression. But when we just look at MRIs of our patients, they're not, there's nothing there that really points to a diagnosis.
Understood. Yeah, and again, kind of our conversations we've had in the last few months, right? Just thinking about, imaging modalities, right? It's not like polycystic kidney disease where TKV was just such a wonderful way to get this prognostic insights, right, into the disease. So understood. So in terms of biomarkers, Tony, do you think so we have the therapies, we have the patients, obviously for trials, just like for PKD, where you enroll fast progressors, right? For ADTKD, you want to do a trial in a finite amount of time, right? So would you say that that's one of the biggest roadblocks to, I guess not drug development, well, I guess drug development or, clinical development in ADTKD, that the fact that, we cannot stratify patients efficiently right now for trials?
Yeah, I think that yeah, as you say, there are two problems. One is we cannot stratify. So we don't know which patients are progressing more rapidly. And then the good thing that we've done with that is we now have 7,000 serum creatinines on these patients.
Right.
So we really need to work on our analysis with you guys of that data, and see if we can predict who's going to progress. But sometimes patients, they may plateau. Their kidney function may stay stable for a while and then start getting worse. We don't know why that happens. And then, as I said before, man, like, I wish we had a biomarker of disease activity. So I say disease activity. If I'm in the car and I look at my odometer or my gas tank, if I'm at half a tank of gas, I know I've spent half of my gas, but I don't know how fast I'm spending it. If I look at the speedometer, I know how, roughly how fast I'm using the gasoline. And so it's similar with kidney function in that we have the creatinine, but the creatinine tells us how much kidney function we've lost. And we just need that marker of disease activity, like urine protein. And then that would just open our door to many, many different medications and diets. And that's why we've been trying to look at different biomarkers. And so that's the most frustrating part of our job. The other thing is to look at direct biomarkers. Like, why don't we just look at like urine uromodulin or urine mucin 1? And I could talk about that for quite a while, but there are a lot of challenges using those two, that they don't really work for what we want to do.
Right. No, that's very interesting. And again, I think that was my last question, but I just want to say that working with you and having the RDCA DAP platform, a CPATH, and the ability to integrate different types of data and to interrogate data across different therapeutic areas, providing working spaces where people can build their own models. I think it really leverages, essentially the building blocks that people have in a particular space, in this case, ADTKD, and and we will continue to work together. And I think, again, there's a lot of interest in the kidney space, as you know from your space, as I know from PKD. I think it's really great that from an industry perspective, people are looking at the kidney space right now, because again, we have a lot more knowledge about the mechanistic side, the ability to identify patients, again, all this novel gene and cell therapy approaches that may be so cool for an indication like ADTKD, for example. So I think the future is bright, and we just need to keep working together, right? And build collaborations and have this pre-competitive space that CPATH and RDC-ADAPT creates, right? To continue building on this. So again, super grateful for the presentation, Tony, and for the insights. And I don't know if there's any other question. I don't see another question. So I think I'm going to pass this back to Dominique to close it out.
Thank you very much.
Thanks so much, Tony.
Thank you.
Dom?
Thanks, Soren. So thank you everyone for attending our conference today. Our webinar today. We're so happy you could make it. We did want to extend an invitation to the 2024 Global Impact Conference that's happening September 9th through 11th in Washington, D.C. This is our inaugural CPAP conference, and registration is open now for it. And we'll be following up the webinar with our recording via email once that's posted. Again, we welcome all questions and comments, so please do not hesitate to reach out. Thanks again and have a great rest of your day.
Thank you.
Thanks again, Tony. Thanks, everyone.